Thank you so much. Sorry, I didn't know that was going to be read out word for word.
Something impressive anyway.
Thank you so much. Yeah, good afternoon, everyone. What an honor to be here. I hope you had a good tea break. I take it if you're on this stream and you're attending this talk, you have a strong stomach. It's not for everybody. When I talk about fungal infections, I know some of my colleagues get queasy. But anyway, yeah, I mean, if you look at DermNet, right, if you were to just Google tinea, you find that the only image that Google automatically blocks is actually the tinea pedis. The other images are considered okay. Yeah, I'm just going to talk about dermatophytosis among migrant workers, what we see in the clinics, and also what the experts say as to what we can do to better manage it. Yeah, I'll be looking at the epidemiology of tinea, both globally as well as here. Specific risk factors that we see for tinea among migrant workers, the diagnostic and management challenges, and also, as I mentioned, looking at what the experts say, a scoping review of recommendations. Okay, so to get the definitions out of the way, when we say tinea, dermatophytosis, or ringworm, we're referring to the cutaneous fungal infections. So not the systemic infections that you see in immunocompromised patients. This is just affecting the skin. It's the fourth highest in global disease incidence. This is according to the 2016 Global Burden of Disease study. And in some parts of the world, it affects up to 60% of the population. About 80% of our migrant patients are from India and Bangladesh, where tinea has been described in very apocalyptic terms, unprecedented, epidemic-like, unresponsive despite adequate courses of therapy with major antifungal drug classes. As for what we see in the clinics, it's the 9th most common declared diagnosis. We had more than 1,000 cases in the fourth quarter of 2023 alone. And this might be higher because we didn't take into account SNOMED terms like pruritic rash or dermatitis not otherwise specified. Although there are some limitations, of course, to this data because it's retrospective, and tinea remains a largely visual diagnosis. Okay, so what are some risk factors that we see more among the migrant workers? We have a warm, humid climate. Tinea is a climate-related illness. The nature of many of the jobs that our migrant patients do are physically demanding. It's performed outdoors, and so they perspire a lot. The attire that they wear as well, long sleeves, trousers, safety shoes for long hours, and also this preference for non-breathable and rather tight-fitting cottons, which, I mean, I got this from what's the fashion trend in India. This was mentioned in some of the papers on tinea written in India. Is this fashion choice that might actually not be helping the tinea issue. And of course, the sharing of wet spaces, such as dormitory bathrooms. So I had a patient who was pretty dejected because he kept getting tinea cruris, and I explained to him that unfortunately, even after your condition is treated, if somebody else with tinea cruris sits on that toilet bowl, unfortunately, the next one who sits will probably also get it. Yeah. So in other words, what we need to prevent tinea, a cool, dry, and well-aerated skin, and some degree of infection control, is really quite difficult to achieve in the migrant population. Yeah. Now, another thing about globalization, part of it is also an imported problem. There's a high prevalence of tinea in India and Bangladesh, as I mentioned, where the majority of our patients are from. And over there, there's a high availability of poorly regulated OTC antifungals, which provide the selection pressure for resistance, especially when there's inadequate treatment with sublethal levels of antifungals. So I've appropriated this antibiotic resistance cycle. If I just replace the antibiotic with antimicrobial, what's happening here is the increased use of these agents provides the selection resistance, and then more stubborn infections, increased use, and then it's a cycle that just perpetuates itself. This resistance is a concern, especially for azoles, because azoles are still considered the most effective antifungal class for the isolates in India. And the resistance level is up to 19% in some studies. And that's quite horrifying because we have not actually had any new classes of antifungals discovered in the last 2 decades. Now, a quick simple one, which of these is tinea? Anybody want to venture a guess? Yeah, so the one in the top left is the most classical description, right? It's the annular erythematous scaly rash. The thing is that all of these are actually tinea. And that tells you what a varied morphology it can have. You know, the tinea fasciae, you have a more pustular, psoriasiform, eczematous-like morphologies of tinea. Yeah, so lots of ways that tinea can present, and to bring special attention to tinea incognito. Here, the use of antifungals results in a change in the morphology of the rash, making it difficult to detect and treat appropriately. So I think the important lesson to learn here is when there is a fungal infection, whether you give a steroid or an antifungal, you will get some altered appearance and symptomatic relief. The difference being that with the use of an antifungal, you are progressing toward resolution. But if you use a steroid, you're actually feeding the infection. Skin of color is another diagnostic challenge. As you know, there's a whole movement now to try and encourage a better representation of how these lesions appear in skin of color. Erythema, for example, is less prominent. But it's not just the case of the palette being of a darker background. Skin of color really does have some differences in anatomy and physiology, which result in a difference in the rash appearance. So the management challenges are pretty much the same as what gave rise to these infections in the first place. So if we could advise our patients, we would want them to stay in an air-conditioned environment, ask them to change their work or their job, maybe wear sandals to work, find private accommodation, and try and screen and treat some of their 8,000 household contacts. But again, that is not possible. So what you have is a pretty typical scenario. A patient, in this case, this patient I saw, the 3rd cycle of itraconazole already. It resolves after a week of treatment, and then a month later, it just comes back again. So because the non-pharmacological interventions, we are quite limited, so there's a greater emphasis or reliance on pharmacotherapy. So looking at our prescription records in 2023, 16,000 plus prescriptions, a third of them required multiple prescriptions, 5% of them were given systemic antifungals, and a minority required multiple courses of it. Now, all these protracted treatments, the incomplete relief, just lead to a lot of frustration for both the clinician and the patient. There's high morbidity, financial expense for the patient, as well as absenteeism, and it is a healthcare burden. Now, so what can we do? I just did a scoping review of some of the recommendations by the experts. I've chosen the US and UK guidelines. If you look at it, they were actually released 10 or 11 years ago. And the later 2 guidelines were from India, where task forces were set up to address specifically, what was mentioned there is that these guidelines don't seem to be working anymore for what we're seeing. There is a general coherence among all the guidelines, just that you'll see a difference in the emphasis on establishing a firm diagnosis and how aggressively it is treated. But I think that's just because of the nature of the context. When you're dealing with recalcitrant infections, the previous guidelines might say, oh, do step 1. If step 1 doesn't work, go to step 2. And the later guidelines will say 1 fails 90% of the time, so just go straight to 2. Yeah, but otherwise, there is good agreement among the guidelines, even after 8 years. Yeah. So the general principles that they all mention is the importance of non-pharmacological measures, Diagnosis of tinea is still largely through visual inspection, but where possible, diagnostic confirmation is desirable. To always consider any differential diagnosis, and that treatment should be extended beyond clinical resolution to minimize the risk of recurrence. So what are the differences then in recommendations? Again, the India guidelines in the context of recalcitrant infections would say, you know, the patient that you see before you has probably had multiple courses of antifungals already and they're still there. So diagnostic confirmation at the outset. The treatment of tinea corporis, tinea cruris, the US and UK guidelines would be to go for topicals. The choice of agent, whether it's terbinafine or miconazole, is more based on cost considerations. As for the India guidelines, they recommend that topicals be used only for the most localized of cases, and otherwise it should be a combination of systemic and topical. Treatment of tinea pedis, I will go into further detail. They're actually very aggressive in the recommendations for how to treat tinea pedis. And the importance of continuing therapy after clinical resolution. Again, the India guidelines just stretch it another week. Okay, what sort of systemic agent to use? It's really more based on things like what is the history of antifungal use, which might point towards some level of resistance. So you might want to change agent. Things like age, which is mainly because of polypharmacy and the risk of hepatotoxicity, but that's more in elderly patients, so maybe not so much in our migrant population. The duration of therapy is guided by the clinical response, and then you extend it as such. But I think it's good to bear in mind that there is a general recommendation for how long the therapy should be, and that's 2 to 4 weeks. And that's because some patients will say that the medicine doesn't work, and they keep coming back. But you realize that they were, say, given 1 tube to cover the whole body, and after 2 days it's finished, and that is not really a treatment failure so much as it is inadequate duration of treatment. So as for tinea pedis, they're very aggressive with it because they find that a lot of cases of tinea cruris and corporis, for that matter, actually start off with tinea pedis, and then there is an auto-inoculation. So they do recommend the use of systemic agents from the outset. And simple things that we can advise the patient would be, even though, say, the fungal infection is at the moment limited to the interdigital clefts, they're supposed to apply that to the entire foot. And then between tinea pedis and onychomycosis, they kind of feed each other. So if the tinea pedis is treated, but the onychomycosis is persistent, then it drives it again. So yeah, so that's why if onychomycosis is seen, then the treatment duration should be extended as such. And that for the toenails is 16 weeks, which is pretty long. Yeah. So in this setting of desperation where they're seeing recalcitrant infections, people are trying to broaden the perspective and say, are there any adjuvant agents that we can use instead of just antifungals? One of them is salicylates, because as you know, one of the mechanisms in fungal infections is hyperproliferation of the keratin, and that's why there's scaly appearance. What this creates is skin layers where the fungus can hide and also affects the drug delivery. So it's thought that salicylates might help with that. Moisturizers, because over time there is some transepidermal water loss and barrier function as well. So maybe moisturizers can help to address that. Antihistamines for pruritus, that's standard. The use of antibacterials. So if, for example, a patient comes to you with tinea pedis, and it's the interdigital clefts are foul-smelling or macerated, then there could be a secondary bacterial infection which also needs to be addressed. These are just recommendations. At the moment, there is no study on what sort of agent to use or how long or the evidence for that, but that tells you that the desperation is there and people are thinking, what else can we do to help? Okay, antifungals and hepatotoxicity. So every agent carries some risk of hepatotoxicity. I just found this meta-analysis of oral antifungals for the treatment of superficial fungal infections and onychomycosis. as expected, the risk of liver injury really depends on the dose and the regimen. So the higher the dose, the higher the risk. And in terms of the regimen, whether you use a pulsed, intermittent, or the one with the highest risk of hepatotoxicity is continuous therapy. So they compared itraconazole, fluconazole, and terbinafine. And the risk of transaminitis not requiring treatment discontinuation was less than 2% for all the agents combined. So if you're looking at what actually resulted in treatment discontinuation, that's even less. I think it was somewhere between 0.6 and 1.1%. I can't remember which number for which agent, but it is very low. In any case, all the guidelines recommend that a baseline LFT be performed and repeated, at least for the India guidelines, 4 weeks after if you are planning to extend the treatment duration beyond. So to conclude, tinea is a major and growing problem. It is a climate-related illness. Migrant workers, for the reasons we just saw, are at particular risk. And I think what we can do at this point as clinicians is really to understand the mechanisms and familiarize ourselves with the guidelines, and that's the least we can do for them. Thank you.
Thanks, Deanna. So I think a lot of men will understand how troublesome tinea is, especially those who have gone to army, right? So when I went to army, I had foot rot, tinea pedis, very troublesome. And when I was working at a makeshift migrant worker clinic in Cochrane a year ago, or 2 years ago, I also started having fungal infection in my body, and not just me, my male colleague as well. So you can see why it's so easy for the migrant workers to get this problem. And often when they come to our clinic, the disease is quite extensive. You know, the picture Deanna shows, it's not just one, it's very frequent. We get that very frequently. Yeah, so it is a big problem. It's very troublesome for the patients. So, any questions for Deanna? Sorry, just got a few questions.
Yeah.
So is there any consensus guideline as to what is the first line, what should be the first line oral antifungal to use for patients who require systemic antifungal?
Right. So that's a good question. So that's why the guidelines say that the choice of agent is more dependent on the history. If a patient returns to you with a recurrent infection, having tried something else before, then you suspect resistance. Otherwise, anything is fine to start with, and all of them have comparable safety profile. Yeah.
So you mentioned sorry, Dr. Lee.
Well, I mean, this is, I'm not evidence-based or anything, but I understand the guidelines for things like light duty really depends on whether you think the employer is able to fulfill that. So I've always wondered, you know, I would really love to, I'm just not sure if their work allows them to do that. But for patients who tell me that, yes, my employer says I can be a signalman for a couple of days, yes, I would advocate that they do that. Yes, but otherwise I think it's quite hard because you know, they take off the safety shoe and then after that a hammer drops on the toe, and then instead of fungus they get a broken toe. So I really make sure that they are able to comply with whatever I recommend. Yeah.
Well, if it's a more extensive you know, tinea pedis, I usually do that, but let's say we just only a little bit, I think they might get away with just, you know, just topical treatment anyway. Yeah. Any other questions for Deanna?
Thank you very much.
Okay, thanks very much.